All right, thanks to everyone who's continuing to pile in. We're going to give folks a few more minutes, as I know calls often end right on the hour, and then we will get started shortly. All right, why don't we go ahead and get started as we have a very full agenda today. I want to make sure we save time for discussion at the end. So first of all, thank you everyone for joining us. For those of you joining us for the first time, my name is Eric Zimmerman. I'm a director at Hadaway Communications, and along with my colleagues who are also on the line, we serve as the secretariat for the STAT communications community. This community, as many of you knew, grew out of the work of the State and Territory Alliance for Testing, a group of, I think now 26 states and territories convened by the Rockefeller Foundation, who share insights, success stories, lessons learned on all aspects of the COVID response. An important part of that has been communications. What's working, what have we learned, and most importantly, when and how do we need to adjust based on facts on the ground? And we're particularly excited about today's discussion because in addition to serving as your secretariat, we will also be one of your presenters. For the last 6 or 7 months now, we've been conducting tracking studies to measure how public attitudes towards COVID have shifted and to update message guidance based on those changes. Today, we're going to share what I think is a really fascinating set of results on how the last 3 months between changes in the administration and probably rollout of multiple successful vaccines now have really fundamentally changed the way the public is perceiving the pandemic. The ways in which they've changed their actions in response to those new perceptions, and how our communications need to adjust to the new facts on the ground. After discussing those big picture changes, we're going to do a deeper dive into vaccine confidence specifically, to discuss what we're seeing sort of about the most important target audiences, the motivations and barriers that they express, and the messages that have proved most motivating to them. However, we know that survey data in a case like this has its limitations. It represents a snapshot in time, and it's also impossible, I think, to capture the nuances of people's experiences and concerns on a topic that is at once deeply personal, but also informed by historical and structural trends that we can't poll test our way out of, to be frank. Likewise, people in this survey may rate how much they like a message for us, and that's incredibly helpful data to have, but whether that message is actually motivating to them, is whether it actually changes their mindset and their action, probably comes down to who they hear it from, the conversation that it's a part of, and who and how they trust the messenger. That's why we're incredibly excited to also be joined by our other presenter today, Dr. Lucy Schulson. Dr. Schulson is an associate physician policy researcher at the RAND Corporation, an assistant professor of medicine at Boston University, and perhaps most importantly for today's conversation, a primary care physician at Boston Medical Center. Her clinical focus is primary care for immigrant populations, and she's also a provider for the Immigrant and Refugee Health Program at the Boston Medical Center. The reason we're so excited to have Dr. Schulson joining us today is that every day, or most days, she has in-depth discussions with patients about their thoughts and concerns about the vaccine and COVID more generally. And she's learned lessons over time about not just what quote unquote messages work and that we should be using, but how to have an authentic and honest conversation built on a foundation of trust about these important topics. And so we're going to show you our data, but we're also going to pause along the way to ask for Dr. Schulson's insight on how it compares to what she's hearing from her patients. So we're thrilled that she's joining us today. And before we move on, Dr. Schulson, just wanted to welcome you to the community of practice, and also just give you a moment to provide a bit more detail about your experiences.
Thank you so much. It's really a privilege to get to speak with all of you today. So I am a primary care doctor. About a quarter of my patients I see through our Immigrant and Refugee Health Center. Many of these patients are asylum seekers, refugees, or coming to the United States through a different pathway, but recently arrived within the United States. I'm also a Suboxone provider, and I also provide primary care for a lot of patients with a history of substance use disorder, and then provide general primary care. Most of my patients are publicly insured. Um, I am seeing patients for primary care, and conversations around the COVID vaccine come up as part of their primary care. So not specifically seeing them for issues related to COVID, but this is part of the primary care, preventative care conversations that we're having. I'm really fortunate that my medical center is able to give the vaccine to our patients. And this wasn't the case at all the hospitals within Boston and Massachusetts recently, but we have been giving the vaccine to our patients, pretty much since it became available to the public.
And thank you, Dr. Schulzen, again for joining us. I know that based on our preliminary conversations, there's a lot of complementary, but which I don't always mean confirmatory insights that our data and your experiences can offer. And I think that's going to make for a really interesting, insightful, and useful conversation. So thank you again for being here.
Thank you for having me.
Before we dive in, I just want to provide a very quick overview of the methodology for the data that we're going to be providing today. We're going to be sharing data from 3 waves conducted in August, November, and now again in February. Each survey was conducted online with a sample of somewhere between 1,100 and 1,700 adults living in the United States. And each wave includes oversamples of Black respondents, Latino respondents, and frontline workers to ensure we have a robust sample to understand the unique motivations and barriers and messages relevant to each of those audiences. The objectives of these surveys are essentially twofold. The first is to track changes in attitudes over time to understand how thoughts about the pandemic are changing. But just as importantly, we want to explore different and important message topics along the way that are relevant to different parts of the response. So our first wave, for example, informed the original testing and tracing message handbook, which I know many of you have seen. The second wave informed the rapid testing message brief, which is a supplement to that first handbook. And this third wave that we'll be talking about today will inform a similar message brief related to vaccine confidence. The other input to that brief will be focus groups kicking off, and I think just about 45 minutes or so, right when this is wrapping up, with vaccine hesitant healthcare workers, K-12 teachers, Latina frontline workers, and Black women frontline workers. All respondents have expressed some type of vaccine ambivalence. So we'll be combining those qualitative insights with the quantitative data that you're seeing today. So, all right, with that out of the way, I just want to sort of dive right into some of the key insights that we've seen in this data that I think it's important that we discuss. So first, it's hard to escape the fact that optimism has skyrocketed in the last 3 months. This is perhaps unsurprising with all the successful vaccines that are being distributed. We also often see a spike in optimism on general national topics when there's a change in administration. But I think what's really interesting is how widespread and how close to home this optimism is going. So for example, we've seen the number of Americans or adults in the United States who think that we're on the right track generally almost doubling from 32% to 60% in the last 3 months, which I think is a pretty remarkable jump. This has translated to how confident they are both in their state's containment. So we see a close to doubling level of confidence in how successfully contained people see COVID being in their state, and also in their local community. So after a brief dip in December, we're now at basically a majority of the adult population who thinks their local community is doing a pretty successful job of containing COVID. But there are signs that we also can't escape that this confidence is starting to come at a cost. So in each of our waves, we've asked about willingness to engage in various protective behaviors: washing your hands, wearing a mask, socially distancing, staying at home, getting a COVID test if you think you've been exposed, and participating in contact tracing. In our first wave, and especially in our second wave, we saw a very widespread and steady levels of engagement, especially for some of the lower barrier activities like washing your hands, wearing a mask, and socially distancing, where up to 8 out of 10 respondents said they were very willing to continue doing this on a daily basis. We were a bit concerned by lower levels of willingness on testing and contact tracing, but nevertheless thought for the most part, our data was showing a different story than what we saw as an increasingly pessimistic media narrative. However, in our most recent wave, as this confidence has increased, we've started to see some signs of complacency. So really across the board here, we're seeing about a 10-point drop in the portion of the adult population that says they are very willing to continue doing each of these things on a daily basis. I think the first thing that this raises for us is that as we continue exploring messages on different specific aspects of the response, we also need to consider messages about perseverance more generally. But before I dive into that, I want to show what I think may be going on with some of the factors contributing to this drop. Um, for better or worse, folks who remain pessimistic about COVID in their local community are continuing to persevere and engage in these behaviors at a very high level. Up to 8 and 9 out of 10 folks who are still a little bit nervous about COVID in their community are still washing their hands, wearing a mask, and socially distancing. Unfortunately, the more confident people are becoming, we're starting to see significant drops, between 20 and 30% drop off in willingness to do these things once you become very confident that the COVID has been contained in your community. If we look at, what are the biggest factors behind this, we were quite, I think, surprised at how confidence is maybe more important than some of the factors that we typically look at for predicting who may or may not engage in these behaviors. So this slide, for example, is just showing willingness to wear a mask by different key variables. We see a 27-point gap between people who are confident in their local containment and those who are not confident in their local containment, with the latter being much more likely to continue wearing a mask. This is slightly larger than the next biggest gap that we see, which is age. So we saw the youngest cohort in our survey, 25 points less likely to continue wearing a mask than the oldest cohort. And then finally, partisanship. Partisanship, I think, has been getting a lot of attention recently as a driving factor behind COVID behaviors, and rightfully so. Thus far in our data, it is a strong but secondary factor to age and an overall sense of confidence. Likewise, if we apply the same test to your willingness to get a COVID test writ large, we see a similar pattern. Confidence in your local community continues to be one of the biggest factors about whether you're willing and eager to get a test. Here we see age as a slightly more important variable, and we see partisanship starting to decline. So one thing that we need to explore is, how do we encourage people to still feel a sense of optimism and where we're heading, but not pair that optimism with a sense of complacency in their day-to-day activities. One thing that we cannot blame, however, for this drop-off is actual levels of vaccination. And we are not seeing that as the people who are actually getting vaccinated who are probably likely for this decline. Those who are very likely and eager to get vaccinated are still participating in these behaviors at a very high level. Those who are already vaccinated are even higher. But it is the hesitant folks, the folks who express some skepticism or concern about whether they will get a vaccine, really showing the most important drop off in behaviors here, with up to a 20-point, 25-point difference between those who are likely to get vaccinated and those who are not likely to get vaccinated. So one thing that we obviously need to explore here is digging into this hesitation, seeing what's driving it, and what are the target audiences that are most important to address. Before we get there, though, I just want to pause and sort of compare this high-level data with the daily experiences that Dr. Scholson is having. So I'd be curious, Dr. Scholson, what other signs of complacency are you noticing in your patients? And what, if anything, has proven successful in motivating them to persevere?
Yeah, thank you. So what I will first just say is that many of my patients are frontline workers. So, throughout the pandemic have not been able to socially distance for that reason. But what I am seeing particularly with some of my younger patients, many who have been living in the shelters or are working in grocery stores. Some of them feel that the pandemic has been going on for a year. They have had multiple exposures or potential exposures to COVID, and they haven't gotten it. And so they, to some extent, think that they are immune in a metaphorical sense to COVID. And I've had one patient say to me, when I'm at work, of course, when clients are coming into the store, he works at a grocery store, I wear a mask. But when I'm with my colleagues, we don't wear a mask. If I haven't gotten COVID yet, I just don't think I'm going to get COVID. So I think that there is sort of a sense of I've survived this long. It's quite unlikely that I'm going to get COVID now. Uh, I will say that I haven't found that many things that have been that successful in encouraging them to wear a mask. One of the things that we have talked about is the risk of bringing COVID home to one's family and other people who maybe could be more vulnerable, and talking about asymptomatic spread of COVID. And I think that to some extent resonates for people. But I think a lot of what I'm hearing is what we're all sort of feeling, which is some fatigue. And then also a sense of I've made it this long, perhaps I'm actually don't need to be using a mask.
Yeah. Yeah, it's one thing that I think is similar in our data that we can't yet tell precisely, but would explain a lot of the trends that we're seeing, is that if it may be that young people who have so far been conducting and engaging in these behaviors for the benefit of more vulnerable populations around them, who now start to see those vulnerable populations becoming more vaccinated, who may actually be the more concerning group than people who have actually been vaccinated themselves. That sounds like it's fairly consistent, perhaps, with your anecdotal experience as well.
Yeah, I've certainly had some patients say to me, especially with how the rollout was in Massachusetts, which started with people over 75 and then over 65, that now I really want my mom or my dad to get the vaccine. I'm really happy that they got it, and we'll talk about this a little bit more. But then they themselves are hesitant to get the vaccine.
Yeah, and that's an interesting sort of transition to what we want to talk about next, which is the degree to which, even if people are supportive of the vaccine, they first and foremost see it as primarily for other people, for whom it's helpful, for whom they're glad that they're getting it, but they themselves are not quite ready to take the plunge, which is sort of the next insight that we wanted to walk through, which that for now, vaccine confidence or a lack thereof really comes down to a waiting game. And what we mean by that is that there are a few different ways that you can define vaccine hesitancy. The first, which we did in the survey, was simply asking people how likely they would be to get a vaccine for COVID if they had the chance to do so. And we ask about that in a fairly traditional way. We see data that I think is not particularly surprising. So overall, 8% of the population reported having received at least one dose. And this is a few, I think, 7 to 10 days old at this point, so a bit of a lagging indicator. 45% very likely to get the vaccine as soon as they have the chance, and about 47% or half of the population expressing some degree of hesitation, saying they're somewhat likely, not very likely, or not likely at all to get the vaccine. The groups where we see that indexing particularly highly are somewhat predictable. It's primarily young people, where we see much higher levels of some type of hesitation. 7 to 8 out of 10 18 to 24-year-olds not quite sure if they want to get the vaccine if they had the chance. Slightly lower levels of hesitation, but still high among 25 to 34-year-olds. And then Black and Latino audiences, similarly, slightly higher levels of hesitation. 66% and 63% respectively, not sure if they would take the vaccine if they had the chance. Partisanship, Republicans are also slightly higher than the overall population. I think one confounding variable here is that we're also probably seeing a slightly higher level of older people in the Republican group. And so if we were to focus on younger Republicans, I would expect that 53% number would be even higher. And then one group where we're not seeing skepticism that we were curious about are frontline workers or folks who are going into work right now in some form or fashion. They are just about identical to the overall population when it comes to attitudes towards the vaccine. However, that's only one way of defining who may be lacking vaccine confidence. The other way in which we asked about this was timeline, not just how confident are you that you want the vaccine, but when would you get the vaccine? When do you think you would be comfortable getting the vaccine? And I think looking at the data in this way starts to tell us a different and more interesting story. Um, so you'll see the numbers on the left here, which is the portion of each group that wants the vaccine ASAP. The numbers on the right are the people who say they've decided they will never get the vaccine. And then you see this light green group in the middle, which are the people who said, I might get it in a few weeks or a few months or about a year from now, or I'm not sure when. It's sort of everybody else. And when you start to compare these different audiences, you start to see that the differences in hesitation are not about the folks who have ruled out getting the vaccine. In fact, if you compare the overall portion of the population who's ruled it out to, for example, the Latino population, which we would typically define as more hesitant, it's identical or even a point lower, certainly within the margin of error. And I think what that tells us is that we are not encountering people who are angry or resistant to the vaccine as much as nervous, cautious, and not sure when the time would be right for them to take action, which I think can sort of inform a lot of the ways that we think about our responsibility and role for messaging moving forward. So to understand what's behind that hesitation, we took a closer look at some of these specific barriers. So we asked a pretty lengthy list of common concerns that people may have about getting the vaccine. The data that you're seeing here is the percentage of each group that rated this concern, each concern, a 5 out of 5. So a very important concern to them. The story in the overall population is pretty straightforward. The vaccines were created too quickly, that being pressured to get them would violate my rights, and that I'm concerned there would be too many side effects. You see that followed by the next highest rated concerns, which is perceived political influence on the vaccine development, more general safety concerns beyond just the immediate side effects, and then waiting generally for others to go first to see how it goes. When we compare those overall barriers to what we're seeing among the most resistant groups, I would say we're seeing a very interesting pattern or a very interesting lack of a pattern. So among 18 to 24-year-olds, the top two barriers are created too quickly, too many side effects. Among 25 to 34-year-olds, created too quickly, too many side effects. Among Black respondents, created too quickly, too many side effects. Among Latino respondents, too many side effects, and I'm waiting for others to go first. And then finally, among the Republican audience, created too quickly and violating my rights. So one thing that's interesting here is how the hierarchy of concerns is almost identical. But I think what's more interesting is just how similar these numbers are between the overall population and each of these groups, which we've just seen, many of whom are much more hesitant or deciding that they're going to wait much longer to get the vaccine. So why aren't we seeing in this data numbers that reflect those barriers kind of standing out at a higher level? I think one is that there's only so much of this nuance you can capture in a survey, and that for the most part, some of the barriers that are out there aren't exactly the ones that we have in mind or that we think to put in a survey. That this may be as much about access as it is about attitudinal concerns when it comes to when you think you'll be likely to get a vaccine. So I just want to pause here again and sort of discuss with Dr. Schulson, who talks about this in a more in-depth fashion with her patients. What surprised you? What might surprise us? So first, what patient populations have you been surprised to learn may lack vaccine confidence, and what concerns are you seeing them express? Oh, you may be on mute.
I have a lot of patients that come from historically marginalized populations or have been minoritized in the United States. What I have found, and I don't have empiric evidence, so I'm also a researcher and I can just say this is anecdotal, but I think is definitely worth exploring, is that my patients who have moved to the US more recently seem to be in many cases more accepting of the vaccine. While my Black and Brown patients in particular who have been in the US for longer seem to express more hesitancy around the vaccine. And what I suspect is going on here is that the longer that they've been in the US, the more opportunities that they have had to experience racism in medicine. and they have had more opportunities to have good reason to not trust the medical system. So that has been one sort of surprising piece for me that I didn't necessarily anticipate. Though, and as I reflect back, it's not actually all that surprising. I am also having very high levels or seeing very high levels of vaccine hesitancy among my patients with opioid use disorder, which surprised me because the majority of my patients with opioid use disorder are white, US born individuals. And I think my own biases that I assumed, they haven't experienced they haven't experienced racism like some of my other patients, but I think that they have had a lot of experiences with the healthcare system that have led them to not trust institutions. And as a result are also very hesitant around the vaccine. I will also say that we focus a lot on confidence and hesitancy, but everyone on this call, who is in the public health world, also recognize how much of an issue really access is, and access to the vaccines and where vaccines are being distributed. Thankfully, my institution is able to give vaccines to our patients, and we have done a really great job of making sure that the vaccine distribution really reflects our patient population. But I think for some of my patients' family members who aren't seen at Boston Medical Center, they have had issues accessing the vaccine. One other issue that has come up that I think is very important to note is particularly with the Moderna and Pfizer vaccine, there are a lot of side effects. And while people are concerned about the side effects, one of the concerns that's come up is that if they are working in a low-wage job where they don't necessarily have as easy access to days off from work, if they're sick or don't feel well after getting the vaccine, they're not going to be able to take off from work. Or I had one patient say to me, well, I'm the only person who can take care of my children. So if I get the vaccine and I don't feel well and I can't take care of them, I don't know who's going to take care of them.
Yeah, that's a really important reminder that when we see things in a survey like concerns about side effects, we often interpret those immediately as just I'm concerned about my health and safety. But the why behind why side effects matter to you is probably important to know, because it's not always just your actual health as much as your day-to-day life and what you need to accomplish that could be driving that concern.
Yeah.
And then secondly, I mean, what barriers may not be showing up in our data? And we've tested a very comprehensive list here, but it's not showing the distinctions that we thought it would. What barriers have you noticed that we might want to consider in our messaging?
So I do think this issue around the side effects and really understanding it, not just as experiencing the side effects in the moment, but how having side effects from the vaccine may mean having to take off from work or, not being able to take care of one's child. While recognizing, on the flip side, if you were to get COVID, you probably would not be able to go to work and, may not be able to take care of your children and could die. So I think that's one really important piece. I do think that there is, I am also hearing a lot around the vaccine was developed too quickly and concerns around that. A lot of my patients, there seems to be some misinformation about who's eligible for the vaccine and for whom the vaccine is contraindicated. I had someone ask me if they could get the vaccine even though they have diabetes, which would be a population that really should be prioritized for the vaccine. Concerns around fertility. There was some misinformation about vaccines impacting fertility, and with my younger patients, who again are not as likely to have complications from COVID as an older population, this is a real concern for them. And so having to spend a little bit of time addressing that misinformation, it does not impact your fertility. And then I think a very real concern for people is that while the technology is not new, the vaccine is new, and we don't necessarily know in 10 years what it will mean to have gotten the COVID vaccine. That being said, one of the things that I talk to my patients about is that we know right now that getting COVID and even getting over COVID, you can have lasting impacts and lasting health issues related to COVID. So it's kind of coming to a risk-benefit analysis that I think is a little nuanced and complicated for most people, really anyone to think about.
Yeah, and then one thing that we've chatted about before is that when it comes to misinformation, one of the biggest challenges is trying to sort of prove a negative, or motivate people to understand that there may not be any evidence for what they're fearing, but you also can't disprove that it's possible. What are some lessons that you've learned about trying to kind of talk people through misinformation in a clinical setting?
So sometimes I try to be very open-ended with my patients in asking them, what are your concerns? What can I, so I just at least know what they're coming into the room with. Um, One thing that I think has been pretty effective for my patients who know me and trust me is that I tell them that I got the COVID vaccine. I have a picture of myself getting the vaccine, which I show them. I talk to them about my own experience and my own hesitancy. I am nursing, and the vaccine was not studied in breastfeeding women. It was not studied in pregnant women, and I talk about that. But I also very much acknowledge that, for me, it is a privilege that I can trust science because I am a white woman and I am a physician. But I think it's been pretty powerful, my just showing them, hey, I've been in this boat, and I tell them about my side effects, my experience. Um, for some of my patients of color, predominantly my African American or Black patients, for a handful of them who have been really frank with me and talked to me about, concerns about racism, both historical and present day, we talk a little bit about one of the developers of the Moderna vaccine, Dr. Corbett, who is a Black woman who's in her mid 30s. I think, and also with some of my younger patients, I talk to them about her because she's a little bit more relatable than sort of, kind of your classic picture of a scientist in his lab with white hair. And I think that there's something that makes it a little bit more accessible, knowing that, someone who looks like me or someone who's a similar age to me helped to develop this vaccine. And that's been pretty powerful. I actually, pull out this article that I have about her that kind of talks about her life and her experience and how she ended up being a part of developing the Moderna vaccine.
And in which ways, and I'm glad you mentioned that because I think it will set up what we've learned, I think, in the messaging session that comes next. But if you can tell through conversation, why do you think that changes their perceptions of the vaccine, or what change in their mindset do you experience in those conversations?
Um, so I think, talking about my experience and my own hesitation perhaps humanizes me and also kind of puts us on the same level. I too was a patient and had to make this decision and deal with uncertainty. And that works with my patients who know me and they trust me. I'm not just some physician, I'm their doctor. For my patients who, we've talked about Dr. Corbett and even looked at pictures of her together, I think there's a sense of pride and a feeling that, I'm aware of the data that particularly early on, a lot of Black Americans thought that Black individuals were not included in vaccine trials. And a lot of our studies previously did not include a diverse patient population. So we talk about that. And I think this is just recognizing that someone that looks like them was a part of the vaccine development doesn't erase, all of the issues of trust, which are very real and very appropriate, but helps to gain just a little bit of trust. I think just seeing someone that looks like them is pretty powerful.
Yeah, and I think a common thread of what you've mentioned there is the distinction between the words on a page that we may read people, but the trust that comes with a relationship and a conversation that's a part of. So with that in mind, I want to walk through the next section here, which is data on our message testing, what we thought was going to work, what ended up working, and what may be responsible for the gap between those two things. So for those of you who are familiar with either the Testing and Tracing Handbook or the Rapid Testing Message Brief, you'll recognize these three themes, which are the message frames that we've developed over the course of our research up until now, that we have found to be effective in motivating and communicating about all different aspects of the COVID response. So they include the frame we call Do Your Part, which is leveraging the idea of social proof to build momentum. So whatever the action is, pointing to others who are engaging in that action around them can build both a sense of responsibility and agency. If others are engaging in this behavior, I feel that I can, and I feel like I should do it myself as well. The second frame is what we're calling do it for them, which is sort of putting people in the picture and emphasizing how various behaviors can protect those that you love, respect, and that those you simply empathize with due to their role in the response. And then finally, the third frame is what we're calling before it's too late, which is a series of messages designed to build a sense of urgency and to take action now. So that involves using loss aversion to describe not just what's to be gained by doing something, but what's to be lost if we don't. And collectively, we have found that doing those two things together creates the sense that this moment is unique and it's important that I take action now. So to that end, one thing we did in the survey was test various messages that leveraged each of these frames, as well as a few new and different messages. So I'd like to just quickly walk through the messages that we tested before we show you all the results, so you can sort of get a sense of what our thinking was for each message. So the do your part message is very parallel in language and emphasis to what we've tested on testing and tracing before. We said that millions of people are doing their part in getting vaccinated to help end this pandemic. If you have the chance, do your part and get vaccinated to help beat COVID-19 once and for all. We tested two different message frames under the theme of do it for them. The first one emphasized friends and family. Getting vaccinated isn't just to protect yourself. It's the only way to make sure you don't give the virus to your friends, family, or loved ones. The second theme here emphasized doctors, nurses, and frontline workers. It's what we call the we owe them message. So we owe it to doctors, nurses, and frontline workers to get vaccinated to end this pandemic. The more cases we have, the more danger they are in of getting COVID-19 and giving it to their families. Under the before it's late theme, we tested two messages designed to build a sense of urgency. The first is highlighting the threat of new and more dangerous strains. If we don't vaccinate people quickly, the virus could continue to mutate and we'll lose our chance to end this pandemic once and for all. And the second is more about an urgency to protect those around you. Every day we don't get vaccinated is one more day we could get COVID-19 and endanger the people that we care about. We need to get vaccinated before it's too late. So those are the categories of messages that are consistent with what we've learned before. But in addition to that, we tested three new messages, both as a control and to see if there were newer insights that would apply to vaccination. The first is what we call the back to normal message. Getting vaccinated is the only way to finally get life back to normal. If enough people get vaccinated, we can safely reopen schools, businesses, and restaurants. The second new message is emphasizing safety. It's what we call the tested message. These vaccines have been tested on tens of thousands of people of all ages, races, and ethnicities. They've been proven safe and have passed strict safety standards in countries all over the world. And finally, what we're calling the they get it themselves message. So this message is constructed based on the advice that the CDC gives to providers for how to talk about the vaccine. So the CDC encourages empathizing with the disruption that COVID has caused, emphasizing safety and effectiveness of the vaccine, and then where appropriate, using your own personal experience to talk about why you got the vaccine as a provider yourself. So very similar to what Dr. Schulzen has been discussing with her patients. All right, so before we show you the results, we thought it might just be interesting to do a quick experiment here and get your take on what message you think performed the best. So Caroline, are you able to launch this poll for us? There you go. So spend a minute, and if you remember the basic idea of each message, let us know which one you think may have done the best. All right, we're approaching full participation, so I'm going to give it a few more seconds here. All right, so it looks like we have a consensus that back to normal or do it for them, your friends and family, were probably the most effective. Not as many of you think that Dr. Schulzen and her colleagues are the most empathetic part of this this equation. So let's end the poll here and then see what the responses suggest. So in fact, most of you were right in the sense that the do it for them friends and family message was the most motivating. But a very close second was the other do it for them message about owing it to doctors, nurses, and frontline workers who have been putting themselves at risk. I would say that between those two, we have sort of clear indication that the do it for them category is proving the most motivating thus far. And the other clear thing that we've learned is that the tested message is the least effective, which I think is an interesting lesson in that just because one barrier may rank the highest, it doesn't necessarily mean that directly responding to that barrier with a one-to-one message is going to necessarily be effective. But beyond that, I think what we're seeing is a cluster of very similarly testing messages. And that could be one of two things. It could be that we haven't found yet a distinct idea that stands out from the rest, or it could be that attitudes and concerns about vaccines are either so entrenched or so personal that reading the words on a survey is not going to necessarily move you particularly in one direction or another. Um, Before we dive into what might be behind that, I wanted to show you just what else we're seeing among the key audiences that we talked about earlier. So these are the audiences that were expressing either the highest levels of overall hesitation or the highest levels of delay. I'm not sure that they wanted to take the vaccine, get the vaccine yet. And we're seeing a somewhat consistent story here among young people, among Black people, among Latinos, and among Republicans. The do it for them messages, the empathy for protecting those around you and those who have been on the front lines of this pandemic um, are the best. There are different levels of success here. Certainly, you see among young people, all the messages performed lower, but the ranking of the messages is pretty consistent. And one thing in particular I want to highlight here, which is while the they get it themselves message tested pretty well among the general population, among the most hesitant groups, young people and Black respondents, it did particularly poorly. And I don't think that's to say that talking about doctors or physicians or nurses or healthcare workers getting the vaccine themselves is ineffective, as much as it's not something that you can assert without the authenticity and the honesty and the conversation that goes with it. So the last thing here that I want to share, which is a bit of a humbling part of the data, is that we pre-post tested, as we say, these messages to see whether people's likelihood to get the vaccine changed from before they heard these messages to afterwards. And what you're seeing is not what we aspire for, which is actually a 3-point drop in the number of people who are very likely to get the vaccine after hearing those messages. Looking at the data itself, I don't think you can blame the messages per se, in the sense that they tested at a level where we would often see at least consistency and if not increases in levels of intensity for those metrics. I think what we're seeing is that people are rightfully very primed to be skeptical and to be on guard for manipulation when it comes to an issue like this. And when you see a message that maybe doesn't rub you the right way, that may be more important than focusing on the 2 or 3 messages that were particularly motivating to you. But either way, I think what we've learned is that the message is less important in this case than the messenger or the conversation. So I know, Dr. Shilson, we've chatted a bit about this in our previous questions, but what other messages or conversational tactics have proven successful with your patients that you think might shed light on some of the data that we've seen so far?
Yeah, I do think, I mean, maybe I'm giving myself too much credit, but I do think showing when we talk about me getting the vaccine, their doctor that they know that they have a relationship with, I think that has been powerful. Because I'm not just some doctor, I'm their doctor. And I think that they, sort of the shared experiences I was mentioning before. I have seen a lot of discussion around race and hesitancy talking about historical racism. And I think that while we need to recognize the historical context of racism in medicine, we also need to recognize how present it is today and the experiences that my patients face regularly in the healthcare system, where they are discriminated against or experience bias, either implicit or explicit, because of the color of their skin or their immigration status. And it's an uncomfortable conversation to have, particularly as a white woman physician. But I do try to sort of address that head on, obviously having open-ended questions, but really trying to kind of unpack why my patients have distrust and be related to the vaccine and beyond. But also recognizing that they're not coming into the room to talk about, their experiences are not because of something that happened in 1970. It's related to racism that they're experiencing every day, and have, experienced in the last couple of years within the healthcare system that may be impacting their decision to get a vaccine or not.
Yeah.
So I think that's just a really important point, and I'm sure that's not new to anyone on the call. But I just, I bring that up because I've seen that there's been so much conversation about historical racism and not so much about racism today. I do feel that talking to my patients about their family members who are more vulnerable and getting the vaccine to help them has been pretty effective. I also just try to kind of create a space where I can let them ask me any questions they have about the vaccine, and give them an opportunity. I've had a lot of patients say to me, I've heard so much, I see so much on Facebook, or I read this, is this true? You're my doctor and I trust you. So I think those are sort of kind of starting points. I really try to use some of the techniques that I've learned in other public health or health prevention. Like when I talk to people about smoking, I figure out sort of where they are in their stages of change. And I think about that with vaccines as well. And it's not like that one, I have the opportunity as a primary care doctor, I see these patients again and again, is that we can talk about these issues. We can talk about their feelings around the vaccine again, when I see them. I think really recognizing that for most people, it is not I'm definitely not getting the vaccine, or I am, it's somewhere in between. And so we can kind of when we meet again, we can talk about it again.
Yeah, absolutely. And I think it actually is a good transition to the Q&A session that I wanted to start now. I know we have a handful of questions here in the chat box. The first question was from the Trust Project. If there's someone from the Trust Project on the line, please feel free to unmute yourself and ask your question.
Oh, sorry, that's me. I'm Sally Lehrman. I should have changed my name. And Eric, I wanted to know, like with you mentioned early on in your research that you felt the media narrative was really at odds with what you were seeing. And Lucy kind of brought that up as well when she was talking about all the reporting on historical racism, but not current racism. And I was wondering if this has changed at all in your view. Is the news media coming more into line with what you're actually finding, or is there still a really real distinction that could be problematic?
Yeah, that's a good question. So I'll give my kind of instinctive take on that, and I'm curious for what Dr. Schulson thinks as well. But I think the first and most important thing is what Dr. Schulson was just talking about, which is I think that when racism in the healthcare, medical, and public health system comes up in the media, it's basically always just Tuskegee, and then we're on to something else, is basically the explanation that we're given. And I think that's not only inaccurate, but I think it has the additional challenge of undermining racial inequities in the healthcare system as a responsible and worthwhile barrier that we need to address for the rest of the population. So I think it's both inaccurate and probably counterproductive as well. The second thing I would note is that it's not, this is maybe a cross section between inaccurate or a self-fulfilling prophecy, but I think there's been a lot of emphasis over the last 6 months on people who aren't acting responsibly, to the degree that that may be responsible for some of the drop off that we're seeing. So we see way more attention to the people who weren't wearing a mask, or who refused to get tested, or who refused to socially distance. And I think that may have primed people to sort of engage in this type of complacency if they felt they were just barely hanging on to doing the right thing for so long. And now that the vaccines are around, they're sort of gonna, what they see as join the crowd in sort of doing, dropping their guard on those behaviors, I think is really unfortunate. So I guess that's what I would see as the distinctions in the media conversation, the data thus far. But Dr. Schulson, anything else that you've seen in your experience that you think conflicts with the media narrative?
I will say I'm also just looking at another question sort of related to this from the Trust Project about how do I draw this out in conversations with patients about sort of racism today. I think that there's been enough people kind of out there saying like, look, we need to stop talking about Tuskegee and talk about racism today, like maternal mortality, pain not being treated in patients of color. In terms of how do I bring this up, this sort of uncomfortable conversation with my patients, is I try to some extent normalizing it. So, asking them about why they're hesitant. And then if the opportunity is there, sort of saying, I understand that for some people that some of the hesitancy comes from distrust in healthcare because of experiences that people have had today and experiences from the past. Just wondering if that's something that you're thinking about, and if that is that something you want to talk about, sort of in creating a space where people can talk about it. I do think that there's more and more recognition that, especially in the last couple of months, right, that racism is not something in the past. I mean, all of us who are health disparities and health equity researchers, this isn't news for us, but I feel the media is starting to catch up a little bit.
Yeah, there's another question here just on sample size for folks who didn't join it at the top. The sample size of the first two waves was about 1,600 US adults. The most recent wave was about 1,200, and each include oversamples of Black, Latinx, and frontline workers as well. Okay, so interesting additional questions here. Gilberto, who will be joining us on the next webinar, had a question about how Black and Latinx audiences compared to white audiences. Gilberto, could you share what was that about a particular aspect of the data?
Yeah, so you had one of the bar graphs. I believe when the question before mine about the sample size, I think it was the same graph. It had Black, Latinx. I was just wondering, then you have Republican, wondering what the bar graph might look like for white, if you have that data.
Yeah, we'd be happy to. We have that data and we'd be happy to send that along afterwards. And I think it shows basically a drop off, basically a proportional relationship between white, Latino, and then Black in increasing levels of hesitation, but with less of a distinction between white and Latino than between, I think, Latino and African American, if I'm recalling correctly.
Thank you.
Yep, of course. Okay, other questions, folks, feel free to unmute yourself and ask if you've got a question for Lucy or myself or for others. All right.
Hi, a quick question. I know we've talked about racism, historical versus present day in public health and healthcare, but I'm curious, Dr. Scholson, on what your feelings are around social justice disparities more broadly. So just thinking about over the past year, where the world has had it has had this point of inflection, especially here in the US, where there's just greater awareness on the social justice disparities and how that's been closely linked to the COVID response and the way COVID has disproportionately impacted certain communities. Just curious to know what your thoughts are on linking this more broadly beyond healthcare and public health, but the social justice disparities.
Which I think the social justice disparities are part of, it is public health, right? Black and brown people being killed by police, that's a public health issue. Or, inability to access food, housing, these are public health issues. These are medical issues. I think it's all very much linked. I will say that I think one thing that as a physician I need to be doing more of is having more frank conversations with my patients about the impact of issues like around police brutality, for example, how that's sort of impacting their everyday life and their psyche. I haven't had as many of those conversations. So I think there's an opportunity to sort of bring that into the clinic room because I think they're just all very, very interconnected. What we're also seeing right now with the distribution of the vaccine is, again, perpetuating inequities that were unmasked by COVID. We're all, I think, pretty aware of the data that shows who's gotten the vaccine and who has not gotten the vaccine. And this is not just about hesitancy. And I think one concern I have is that the narrative that people of color don't trust the healthcare system and therefore aren't going to get the vaccine is going to be used as justification or a explanation for the inequitable distribution of vaccines. I'm not sure if that answered your question, but I think that these issues are all incredibly important and very much related to public health and medicine, and very much within the realm of public health and medicine. Did that answer your question?
Certainly, thank you.
All right, and we have 1 or 2 minutes left here, so glad to take any other questions that folks may have. All right, well, hearing none, I want to thank you all again for just taking the time to join us, and especially Dr. Schulson for joining us with her, not just her thoughts, but also her experience and knowledge and conversations that she's been having. I think it's an incredibly important addition to the type of data that we often discuss in these settings, which, while useful, don't really tell us the whole story. So thank you again for joining us. I will go ahead and jump off as we have focus groups starting in about 90 seconds that will help answer some of the remaining questions about vaccine confidence I know we're all wondering about. We'll be sharing those insights, combining it with the quantitative data on a future webinar session again. So keep an eye out for that. And again, we'll send out the recording and the recap after the call. And thank you all for joining us.
Thank you for having me.
Thanks, everybody. Great session.
Did you see my note in the chat box? Okay.
Yeah.
All right, I'll see you in the focus group session.
Thank you. Bye.
Bye.